How's it going, guys? Past level question for hepatobiliary step 1 internal medicine surgery 2CK 38-year-old man. 1 day history abdominal pain, fever, chills, hospitalized 1 year ago for a similar episode. Ultrasound, CT of the abdomen are negative. He's commenced on IV fluids, antibiotics. He has history of ulcerative colitis managed with sulfasalazine. He's febrile, 38 Celsius, heart rate 90, respiratory rate 16, blood pressure 130/90. Physical exam shows jaundice and epigastric tenderness without rebound or masses. Total bilirubin elevated 2.8 milligrams per deciliter should be 1. And the direct fraction should be 0.1, which I didn't give you here, and it's not relevant. You can infer it, okay? Alkaline phosphatase elevated 350 should be 50 to 150. You don't need these lab values to answer the question, okay? As I'll explain as we move through. Choice A, acute cholecystitis, wrong fucking answer. So this patient has jaundice 29 out of 30 times in acute cholecystitis, the patient's not going to have jaundice. Okay, cholecystitis means inflammation of the gallbladder. So cholelithiasis is stones in the gallbladder. So biliary colic, okay, epigastric pain or right upper quadrant pain that's worse after meals. Fat, 40s, female fertile for cholesterol stones can be pigment stones, conditions with increased RBC turnover such as hereditary cirrhosis or sickle cell. If you add a fever on top of that pain, we call that cholecystitis. Now, if you, let's say, have a concurrent stone that has descended out of the gallbladder into the common bile duct causing obstruction, where we have a choledocholithiasis on top of a cholecystitis, sure, we could get jaundice, but in isolated cholecystitis, we're not going to have jaundice. And you're going to do ultrasound to diagnose, followed by a HIDA scan if the ultrasound is negative or equivocal. Choice A, wrong fucking answer. Choice B, acute pancreatitis, wrong fucking answer. I mean, we don't really have demographic per se. I mean, we have ulcerative colitis. That's relevant, as I'll talk about. Not related to pancreatitis. They can mention history of alcoholism. And jaundice at the same time. I mean, you could have gallstone pancreatitis, right, causing so choledocholithiasis causing pancreatitis if the stone has descended in the common bile duct where it's obstructed the hepatopancreatic ampulla. Okay, the question would probably give you an elevated amylase or lipase. They can also give you hypocalcemia. It's exceedingly high yield. I've talked about it in my content. So if they give you, let's say, an alcoholic who has abdominal pain, fever, and hypocalcemia, very, very buzzy for pancreatitis. Wrong fucking answer. Choice C, Budd-Chiari syndrome. Wrong fucking answer. Okay, so students who aren't sure what's going on, they may have heard of it before. They choose weird sounding diagnoses. This is hepatic vein thrombosis. It's low yield for USMLE. It shows up, but very, very low yield. Okay, so patient can be pregnant. That can be a demographic that gets Budd-Chiari syndrome. Can be hypercoagulable state, let's say a setting of malignancy. Patient has e.g. lung cancer. Okay, so we think about propensities for thromboses, but wrong fucking answer. Choice D, primary biliary cirrhosis, wrong fucking answer. Positive anti-mitochondrial antibody is going to be a woman, 20s to 50s, who has generalized pruritus, jaundice, high ALP, high bilirubin. They can mention history of autoimmune diseases in her or a family member. Okay, they can say she has history of autoimmune thyroiditis. She has vitiligo. Her brother has rheumatoid arthritis. Very, very buzzy. Okay, they can give you a big rambling 15-line paragraph in 2CK. In the last line, they can tell you that there's a stone visualized in the gallbladder. That confuses students. They're like, oh my God, there's a stone. Well, there's high cholesterol. You get cholesterol stones. Wrong fucking answer. Choice C. Actually, real quick, I'll just say, you can give ursodeoxycholic acid. That can show up on NBME, aka ursodiol, as a treatment for primary biliary cirrhosis. As I already said, wrong fucking answer. Choice A, primary sclerosing cholangitis, correct answer. So pass level, as I said, because ulcerative colitis, you got to know it's an extraintestinal manifestation of UC. Okay, very easy. So, and I also give you Charcot triad, CHARCOT, Charcot triad for cholangitis, which textbook is going to be right upper quadrant pain, fever, and jaundice. Now, I didn't specify right upper quadrant pain. Why did I not specify that? Because the NBME doesn't necessarily specify it. Okay, they'll just say abdo pain, fever, and jaundice. And the student's like, OMG, they didn't say right upper quadrant. Doesn't fucking have to be. Okay, so, and we eliminate to get there. You say UC, I know that's associated with primary sclerosing cholangitis. So cholangitis means inflammation of the bile ducts. Okay, and you can have a negative ultrasound CT, which you tend to do first. I've seen ERCP as the next best step in diagnosis for cholangitis on USMLE. Okay, so you ulcerative colitis, primary sclerosing cholangitis, and Charcot triad. Abdominal pain, classically RUQ, doesn't have to be, but abdominal pain, fever, and jaundice. Correct answer. You know the deal. I'm going to make more content. Like my stuff, subscribe my channel. Appreciate your time. That's it.